Parotitis, the second, November 18th, 2024. Today we're going to focus on neonatal suppurative parotitis. The key points to take home here is that parotitis is inflammation of the parotid gland, which is one of the salivary glands in the head, and this can occur due to, for example, infections, obstruction, or inflammation itself, such as in autoimmune condition or trauma. When it is caused by an infection, the cause is usually a bacteria known as Staphylococcus aureus. The second most common would be Streptococcus agalactiae, which is a group B Streptococcus, which is known to rarely cause autoimmune complications that can involve the heart, kidneys, and other organs. And then the less common causes are other bacteria such as gram-negative bacilli or anaerobes, or atypical organisms such as fungi can also cause parotitis. When this parotitis occurs in a newborn, it can be termed neonatal suppurative parotitis when it is caused by an infection. Suppurative itself is a synonym of purulent, basically something that produces pus. So this is usually an infectious cause. And this occurring in a newborn is a rare condition, manifesting as the general manifestation of an infection, including fever and local inflammatory signs of the affected organ. In this case, it's the parotid gland. So erythema or redness, local swelling, and tenderness or pain to the touch usually occurs locally around the parotid gland, which is just in front of the earlobe of the auricle. That's the location of the parotid gland. The risk factors that increases the likelihood of this occurring is that things that produces or promotes dehydration, such as prematurity. There's increased water vapor from the body of the newborn. Therefore, it is easier for premature newborns to suffer from dehydration. And when dehydration occurs, anything that involves the production of fluid in the body, including salivary production, the production of saliva in the parotid gland, is also reduced. Therefore, the secretion or the saliva is thicker and harder to move through the channels, therefore increasing the risk of blockage or even concretion. Concretion is basically the saliva drying out and forming a sediment, which when large enough, it forms what's called salivary stone, or the medical term is sialolith. This increases the likelihood of parotitis occurring. Dehydration causes a condition that promotes hindrance of the salivary flow, therefore it promotes obstruction, and thus when the salivary duct is blocked or obstructed, the bacteria there, the normal oral flora there inside the gland, can then flourish because there is no outflow of the fluid where they reside. In addition to that, malnutrition can also increase the likelihood of this occurring because it impairs the immune system when you're malnourished. And there are certain infections that can also increase the likelihood of the newborn suffering from parotitis. And this is the cytomegalovirus infection of the mother. It increases the likelihood of the newborn from suffering NSP, or neonatal suppurative parotitis. When the mother uses methyldopa, which is an antihypertensive, it also increases the risk of the newborn from suffering NSP. The use of oral devices such as oral gastric tube and oral suction can cause damage to the oral mucosa where the salivary duct is. So basically anything that involves a device being used in the oral cavity or through the oral cavity of the newborn, there's a risk of injuring the salivary duct, therefore causing impaired outflow of the saliva and thus increasing the chance of parotitis to occur. Imaging that can be used in NSP include ultrasound as the first line because it's fast, relatively fast and non-invasive compared to other modalities of imaging, and it is also capable of detecting parotid abscesses and other differential diagnoses rather easily. CT or MRI is usually reserved when ultrasound does not exclude a differential diagnosis while the persistent suspicion remains. So clinical suspicion remains that there is a complication, but ultrasound does not detect anything, then CT or MRI is usually used because it provides better imaging results. Conservative management include empirical, meaning the antibiotics here should cover most of the common causes of the parotitis. And then also symptomatics relief. So fever, you give fever medication, etc. And then this antibiotic regimen should then be readjusted based on what the culture of the pus or the antibiogram of the pus of the sample shows. Let's say the empirical coverage you have given to the newborn, and then the antibiogram or the culture shows that it is an anaerobe, only an anaerobe. Therefore, you should change the antibiotic into one that specifically attacks that anaerobe pathogen, because we want to be as specific as possible with the antibiotics we use to reduce the likelihood of resistance. Surgical procedures for NSP is usually reserved for cases that does not respond well 24 to 48 hours after appropriate conservative treatment. Complications are rare since the use of antibiotics, and this includes fistula, which is the body's attempt to extract or get rid of the pus by creating an artificial tunnel through the skin, forming a sort of abnormal hole that connects the outside world to the abscess or the pus inside the parotitis. Mediastinitis, which can result from the pus traveling down through the muscles of the neck into the mediastinum, the space containing your heart, and vagal palsy, because vagal nerve runs through the parotid gland most of the time, and mastoiditis, which is inflammation of the mastoid bone, which is in very close proximity to the ear and to the parotid gland thus. These are some of the examples of the complications that can occur in NSP or parotitis in general. As we have mentioned, parotitis itself can be infectious. And here is a case report in the study that we're going to discuss right now in a 21 days old neonate with right preauricular swelling and inflammatory signs that extend to behind the ear, to the retroauricula. And this neonate presented with fever since 2 days before being admitted to medical attention. And the baby itself is born normally in a normal pregnancy without complication in utero and with no history of trauma, and was breastfed at home and had normal stool. And then the baby developed inflammatory signs in the preauricular region, starting with swelling and then redness that rapidly enlarges. And during this period, there were no history of trauma to the patient's head or neck, and there's no history of skin infections on the mother nor the newborn previously, nor there are any signs of mastitis, inflammation of the mammary tissues of the mother. There were no history of that. The mother denied this. The mother denied signs of these conditions. They didn't occur. And then At admission, patient was alert, non-toxic, and well hydrated. The swelling in the right preauricula was hard, red, tender, and visibly swollen, to the point that it slightly displaces the right ear externally. And it was noted that there was a purulent or pus coming out of the Stenson's duct, which is the main salivary duct that puts out the salivary excretion into the mouth, which is located in the oral mucosa just beyond the cheek. Lab results show C-reactive protein to be elevated at 250 milligrams per liter, which is a strong indicator of inflammation, especially one from infection, although it's actually non-specific. Lumbar puncture and examination of the cerebrospinal fluid obtained reveals normal results, and samples were sent to culture where it include blood sample, cerebrospinal fluid sample, and urine sample, which all turned out negative except for the pus coming from the Stenson's duct, which comes out positive for Staphylococcus aureus. CT scan of the head and neck shows a swollen with heterogeneous enhancement of the right parotid, which signifies inflammation, but there were no abscess, no fluid collection inside the parotid gland, and there was significant infiltration of the right parotid spaces and masticatory spaces, meaning the inflammation is now spreading. These findings all support the diagnosis of neonatal suppurative parotitis, and then treatment with IV antibiotic was then started with ceftriaxone 100 milligrams per kilogram a day and gentamicin 3 milligrams per kilogram a day for 2 days. And after those 2 days, there was clinical improvement, and the patient was then continued on oral antibiotic for 10 days, namely cefpodoxime, and 2 weeks after, on follow-up, the outcome was good for this patient. This picture is the clinical picture of the patient where there is very clear erythema pre-treatment. This is at admission. The picture A on the left is pre-admission. There is erythema on the right cheek and swelling that extends into the auricula. You can see the auricula is actually swollen and erythematous as well, redness. And also, this extends to the back of the ear as well, to the retroauricula. And then 2 days after intravenous antibiotics, you can see that the ear and the area behind the ear is actually now devoid of inflammatory signs. The inflammatory signs has shrunk to just anterior or in front of the auricle, and to a lesser degree as well. The swollen is not very visible, so there's clinical improvement, and then the patient is continued on oral antibiotics. This is the CT scan of the patient showing a swollen right parotid. This is the sagittal view of the CT, and this is the axial. Sagittal is as if you're looking at the patient's cross-section from the side. Axial is from the bottom, and this was in his coronal, as if you're looking at a cross-section of the patient face-to-face. The red arrow signifies the inflamed parotid gland on the right side of the face, where there is heterogeneous enhancement on this CT, along with swelling of the parotid spaces and masticatory spaces around the parotid gland, that is signified with the yellow arrow. As we have mentioned, parotitis is uncommon in children and even more uncommon in newborns, and the parotid gland, which is one of the salivary gland of the head. The other one includes the submandibular gland. The parotid gland itself is most susceptible to parotitis because it exclusively secretes a serous secretion, which is devoid of immune components or barely contain any, while the mucoid, the thicker secretion that is present in submandibular glands, is absent in parotid gland. Therefore, parotid gland secretions are very susceptible to attack by pathogenic bacteria or other germs, making it more susceptible or most susceptible to infection causing parotitis. The incidence of this purulent parotitis occurring in newborns, that is NSP, it contributes to 3 to 14 out of 10,000 admissions. And there is a male preponderance of incidence where male cases are 3 times more common. This was not discussed in the study. And the risk factors that increase the chance of NSP to occur is number 1, prematurity, because it predisposes the newborn to dehydration, and the dehydration itself, malnutrition, because it impairs the immune system, low birth weight, also in line with malnutrition and impaired immune system, and prematurity. Ductal stasis of any cause, let's say thickened saliva production because of dehydration, or blockage by tumor, mass, or stones. Oral devices or any sort of procedures that can cause trauma to the oral mucosa can injure the salivary duct and thus block the outflow and cause parotitis. NSP can also result from, again, reduced salivary secretion and congenital ductal malformation causing obstruction and thus causing blocked outflow or stasis of the salivary production. And then obstruction can therefore cause dilation because the content is blocked and then accumulated. And this produces a good environment for the pathogens to proliferate and then cause infection. This blockage can also be caused by stones or masses or tumors such as lymphangioma, hemangioma, which are usually congenital. Adenoma, lipoma as well. There's also a possibility where any infection elsewhere in the body spreads through the blood of the patient to another site in the body, including the parotid gland. This is called hematogenous spread. And contaminated milk formula or contaminated or infected mammary tissue of the mother can also transmit the pathogen, therefore causing parotitis. Congenital infection of the mother by cytomegalovirus or maternal methyldopa use also contributes to higher risk of parotitis to develop. Trauma to the oral mucosa again, and also infection of sites around the parotid gland, such as maxillary infection, such as in the case of poor oral dental hygiene, can also result in parotitis. The manifestations, the non-specific one, include fever and local inflammatory signs of the affected site, that is, the parotid gland, such as swelling, erythema, redness, pain to the touch, etc. This usually occurs 7 to 14 days in the case of neonatal suppurative parotitis, 7 to 14 days after they were born. When a pus is present out of the Stenson's duct, is pathognomonic to diagnose parotitis, but it is not always present. And this pus is also sampled for culture and then antibiogram. NSP is usually unilateral. Bilateral cases are possible, but it's very rare. The causes most commonly is caused by Staphylococcus aureus, and in 25 to 40% of cases, it's also caused by what's known Streptococcus agalactiae, a group B Streptococcus, known to be related to the development of rheumatic diseases that can affect any organ, but it is rare. In the case of nosocomial or hematogenous spread cases, gram-negative cocci is more common, such as Streptococcus pyogenes, Streptococcus, and Viridian Streptococci. Viridian Streptococci is the common inhabitant of the teeth surface. And less common is the gram-negative bacillus such as Klebsiella pneumonia, Escherichia coli, and Moraxella catarrhalis, and other pathogens that are not bacteria. They are also less common. And in rare cases, anaerobes are also involved in the infection. And recently, multi-drug resistant strains have been reported. The imaging, the first line would be ultrasound because it's non-invasive and speedy, and it is thus preferred for newborns. It can detect tumors such as cysts or concretions such as stones or parotid abscesses, and it can also detect retropharyngeal abscesses. This imaging is usually recommended when those cases are suspected or when 2 days of appropriate treatment does not yield significant improvement clinically. When there is negative result in ultrasound, but there is still remaining suspicion of complication, CT and MRI can be considered because they provide better imaging results so that it is more reliable to exclude the differential diagnosis or the suspicions that we still have. The complications that can occur include fistula formation, facial nerve damage, manifesting such as into facial palsy, spread of infection into nearby regions such as the brain to the external ear canal or to the mastoid bone, causing mastoiditis, or even the pus traveling down into the mediastinum, causing mediastinitis. The management, first of all, principally conservative management first, with systemic antibiotics that covers a wide coverage of bacteria, wide spectrum of bacteria, and also symptomatic medication. This is usually, the antibiotics is given usually for 7 to 10 days, but when in severe cases such as signs of organ failure, etc., or if there is an anaerobe, usually this period is extended. Surgical treatment, that is drainage of pus, is only indicated when there is abscess or considered when conservative treatment fails after 2 days with no clinical improvement. The regimen itself, the antibiotic regimen that is used, can use first generation cephalosporin or penicillin that is resistant to beta-lactamase for a wide coverage of the bacteria. And this especially covers for S. aureus, and anaerobic coverage is also added to cover for potential anaerobe presence. And then this ideally is readjusted to the result of culture or antibiogram to specify the weapon that we are using against the bacteria. When MRSA is detected, which is methicillin-resistant Staphylococcus aureus, usually this is multi-drug resistance to multiple antibiotics. One of the antibiotic that can be used is vancomycin. And antibiotics that can be used for anaerobe coverage to basically kill anaerobe bacteria include cefoxitin, clindamycin, imipenem, penicillin plus beta-lactamase inhibitors such as clavulanic acid, or macrolide plus metronidazole. Thanks for watching.